Everybody, on a Monday, I got a couple of doctors hanging out with you. It's Brett Harris. There's Jody. There's, of course, Denny. Maybe Sal Barbaro today to start a week, guys. How the heck are you? Denny, I just heard you got back from Austin.
Yeah,
Jody, what about
a
you?
little
What's
late, but yes.
okay?
Well, looking forward to a busy week, and it's a beautiful day.
Yeah.
Wow,
It is.
the weather's great, and after last night, I actually stayed up late last night,
Mhm.
anticipating that there might be a
I know.
tornado warning or a big storm or something. We didn't quite get it here, so it missed us. But wow, you know, I think that the ones that strike at night, if there's a tornado at night,
Right.
a lot more people get hurt.
Yeah.
You know,
Well,
because
we're celebrating yesterday was the Andover, what did they say? 35 years, guys. I mean,
It's hard to imagine it's that long ago.
Yeah.
it seems like maybe a couple of years ago we were all here, but I'm with you, Joe. I'm as any Kansan, we take severe weather very seriously.
Yeah, and I remember the Andover tornado because I was working at the hospital, and I looked out the window, and the hotel, or it wasn't a hotel, it was at the hospital, but the hospital window was about even with the tornado in height. So the tornado went right by.
Mm.
Gosh.
It was just like next door.
Yeah.
Mm.
And I thought, oh my gosh, that is just terrible, and that somebody's going to get hurt.
Yeah.
And then, of course, that
That
happened.
building was made, though, to sustain tornadoes,
Yeah,
right?
yeah.
Yeah, it was. Well,
Yeah.
guys, as we start a week, we've got a lot of things, open topics to talk about. I know there was a little discussion early on about the press dinner, Donald Trump, and an attempt on that. And you guys were talking about violence and overall violence that's going on in our country right now. I overheard you two docs talking about it. And Jody, I'll start with you. Why is that on your mind today?
Well, I think it's prevalent in our world. I would say that there's more violence now than we've had, and nobody can be sure exactly why. Political parties really scorn each other. There's not much respect back and forth. I think that's one thing that contributes. Denny and I were talking. The internet. You can say something really bad about somebody and not take credit for it or blame for it. You can just put it out there, and that is how some of these bad feelings are generated. But it's not just here; it's all around the world, actually, that there's an incidence of violence to worry about. And one of the things that worries me more than anything is just these spot shots where it's not like somebody comes in and invades your country, but as what happened, Denny, in Austin not too long ago.
Mhm.
It was at the university, probably one of the safest universities I know of, in a fun part of town, and somebody just drove by and fired a weapon in there and hit, I think, 12 kids and killed 3. And, I don't know how you prevent that. And the incidence of people who feel good about that is much higher than you would ever imagine. To me, if you just heard about that, you'd say that is just terrible. But there are people who say, well, they deserve that, or when it comes to Trump, the guy's a bad guy anyway, so so what? Something ought to happen to him or somebody else that they don't agree with. I don't know how you approach that.
I don't either, but I think what we've lost here is some civil discourse with someone. If you disagree with people, if you could sit down and talk about it, you'll often find some compromise or some things you do agree with.
Right.
But that doesn't happen today.
Yeah.
It's all just throwing insults to each other, and it seems to be, and to me, it's inciting anger across the board. So then you get people that are just a little crazy, to be very honest.
Yep.
And then they go bonkers, like this guy that rushed the group, the attending group there the other night. So,
and they can rationalize it by
Yeah.
saying, well, they criticized us, or there's not a lot of ways that people can find some unity. And I thought it was happening for a little bit at the party Saturday night. At the beginning of it,
Mhm.
people were
Yeah.
friendly to each other.
yeah.
And then afterwards, everybody was feeling sorry for all the people there and the president and his wife and everybody that were really stressed out. I think the whole country was stressed by that event.
Well, there's
And
political
everybody watched.
there's political stress in our country. There really is, and that's what you guys are talking about, and it's exhausting. I mean, all the way. Everybody hates everybody, and then we here in town. We were just talking about it. Our mayor gets a death threat, and that dude's in jail. So we're getting it locally and nationally. And I echo you guys. It wears you out. It wears you out how many people are trying to hurt the other party, right?
Yeah.
Right. What I would like to hear is somebody saying something good about their opposition. Anything. Like last night, I thought right after that happened, there was a lot of sympathy for everybody. But then at the end of it, there was like criticism back and forth, and why didn't they do this right? And, it was not so. Then it became more like, well, now we're trying to put blame on somebody again. And, like recently, I remember this fellow that was representing the insurance company, and he got shot in New York.
Oh, yeah.
And actually, I was there down the street when that happened. And I remember, I thought, oh my gosh, that's just horrible. I mean, I didn't know him personally, but, he got shot in the back as he just was walking into a meeting.
Mm-hmm.
And immediately there were people who said, what did that guy do? And they said, well, he was the CEO of a health insurance company. And there were a lot of people around me who said, boy, he deserved it.
Yeah.
These prices are too high. I'm like, geez, to get shot in the back? I don't think so. But there seems to be kind of an acceptance of that happening by too many people.
Mm-hmm.
Mm-hmm.
And I don't know what you do about that.
I'm not sure either.
No.
But we somehow have to figure out how to slow down the rhetoric here and slow down the animosity between people.
Yeah.
Because it's not going to be good going forward.
Well, and I think the other thing is, there's always been a lot of back and forth chatter when there's an election year or whatever.
Let's welcome in Sal Barbaro. Sal, the guys are talking a little bit about the hostility level of everything that's going on in the country, that we're talking about the press secretary's dinner and the threat on the president's, and just how everybody's mad. That's what you're jumping into that end of that conversation. How's Mr. Barbaro today? What are you doing?
Good. Just finished clinic.
Okay.
Finished clinic. Did some cases today, and just going along. Going to be in New York at Mount Sinai on Wednesday and Thursday, doing a thrombectomy course, another device to pulmonary embolism clots. And going to go to a Yankee game on Friday.
Are you going to cheer for the Yankees?
Yeah, I'm a Yankee fan. I'm Bronx Bomber.
Okay, tell us about thrombectomy. Why do you try to take the clot out, and where? What kind of a device is that?
It's a device used to remove a clot. Usually, the clot forms in the leg. It doesn't have to be. It can form in other parts, but travels back through the veins up to the heart. And as you know, on the right side, blood travels to the lungs, and if a clot gets in there, you cannot oxygenate, and you could die from a massive pulmonary embolism. So most of these patients that come in, they're acutely short of breath, and they are hemodynamically sometimes unstable. Their blood pressure may be low. So the idea is to try to get the clot out so you can reestablish flow.
Yeah. Mm-hmm. Now, in the old days, Denny, somebody came in with the clot in the leg and it embolized to the heart.
Yeah.
Sometimes they would just die right in front of you.
In the Unfortunately, yes, that's true.
And I'll never forget one time I was working in one of the rural hospitals, and a guy he didn't walk in, he was brought in, and he just couldn't breathe. He was just panting. And he did have a pulmonary embolus. And he kept saying, I feel like I'm not going to make it. I feel like I'm not going to make it. But at the time, all we could do was give him heparin, a drug to try to dissolve the clot, but it doesn't really dissolve it. So we had other drugs that we reached in a cabinet for to dissolve the clot, but it just didn't work quick enough. So he just passed away because he wasn't getting any blood in his lungs. But in today's world, if somebody comes in with that kind of a problem, Sal, and you've got a half of a chance, a minute or two, a little bit of time, you can actually go in and pull that clot out or cut it up. How do you approach that? Is that what you would do with this device?
You don't really cut it up. It's mostly it's kind of like huge suction device. You really you're sucking out the clot.
Yeah.
And that's how most of them work. And there are various devices on the U.S. market, different companies. Um, I'm just trying to get proficient in one of them. So this is it's not extremely hard procedure. It just requires a lot of patience and just the ability to get those lines up into the area of the lung where you can get to the clot is just a little bit. That's the difficulty of it. But once you get up there, you should be okay to go.
Do you go into the groin to get there?
Yeah, you're coming from the groin. The angle is that you have to come in and cross the valve and then go back and go up towards up the pulmonary artery, past the pulmonic valve, and then you have to get into depending on which lung, the right or the left, lung to try to get to that clot and get it out of there.
Well, that takes a little bit of skill.
Takes a little bit of skill
and some time. Not a lot of time usually if everything goes well. But you're right. You can then situate your catheter in front of that clot and then remove the clot or give some kind of a medication to perhaps help dissolve that clot. But everything in today's world would be designed, well, not everything, but mostly to actually take the clot out. Yeah.
Which is kind of interesting. One of the interesting things, as you might remember, Dr. Galicia, was we used to try to do that. We can actually still do it in the heart, but the trials have shown that, the idea of doing a thrombectomy, or, sucking out a large clot really didn't show any difference than simply just trying to break it up with a balloon. Thrombectomy for coronary work, heart artery work has kind of lost favor, but in the lung, it's obviously the treatment of choice.
Yeah, and these clots tend to be big,
They tend to be big.
A larger clot those are pretty good sized veins there, or arteries in the lung, and so you have to remove a fairly sizable clot to make things work properly.
And you're going in the artery to come up there, or a vein?
You're going in the vein.
That's what
You're going in the vein. You're coming up through generally you're coming up from the femoral vein up into the right side of the heart. Remember, it's the kind of like trick question on most, when kids go to school or whatever, what are the only arteries that carry deoxygenated blood and what are the only veins that carry oxygenated blood? It's the pulmonary. You're going in the pulmonary arteries, which have deoxygenated blood.
Mm-hmm.
But again, blood's got to pass through the lung, get oxygenated, and returns through the heart to the heart from the right and left pulmonary veins, oxygenated. But so it's a little bit confusing but that's what we attempt to do.
Yeah.
Now there's always the other option is always to give clot busters, give lytics, we call thrombolytics. But in the decision whether to give thrombolytics or do thrombectomy, there are different indications and situations, but that's what we end up doing.
Yeah. You remember the story I told a moment ago? It was in an attempt to use the lytic drug. Yeah. We were in a situation where there was no possibility for trying to get the clot out. So we just try to dissolve that clot. So what we're talking about here is blood flow to the lung, which is absolutely critical to become oxygenated. So then it can be used by your body. And
right.
And that's
what usually happens is rarely are they going to pass out. Those are the ones that are those are the massive, what they call saddle pulmonary emboli, where it sits right there at the point where the two lungs, right at the point where the two, pulmonary arteries come off. So it's blocking flow to both lungs generally. That's called a saddle embolus. Most of the time it's further downstream into one lung or to the other. And usually they come in, complaining of shortness of breath. You end up doing a blood test. D-dimer level sometimes is up. It's positive, and then you do a CT scan, and which will show that you have a clot. You won't see flow going through part of that lung that's involved, and so that's what the general sequence of events are.
When you have a saddle embolus, there's no blood flow that can go through to the lung, period.
Right,
So
right.
very often those people die
They usually
quickly.
die quickly.
You don't have a lot of time.
Yeah,
And don't they often end up having an arrhythmia that leads to their death? I mean, because you're not getting oxygen anywhere very well.
Yeah, that's part of the problem. Yeah. I was going to go over a couple.
Well, it's not that you're not only getting oxygen, then your lungs actually are able to oxygenate. You're not getting blood flow.
Blood flow.
Blood flow. So that's the critical thing. So no blood flow is the heart. The right side of the heart massively dilates in response to those high pressures now caused by those clots.
Mhm.
So now you have right heart failure. And then usually when you have that kind of thing, you become hypotensive. And it's just a sequence of events, which comes first, whether you have an arrhythmia or, you drop your blood pressure, you're in critical situations.
One of the questions that patients often ask is, why did I get this? And it's one of the things that happens when we do surgery of any type is that is one of the complications of surgery, especially like anything, abdominal surgery, anything that requires you to be, let's say, in the prone position or sitting somewhere for a long time. The guy that I talked about at the beginning of this show had spent 18 hours on a plane, and he said he never moved. He slept the whole time. And then when he got up, he was short of breath, and then he started coughing up blood. And then by the time we got a hold of him, he had a saddle embolus that was just not resectable. Oh boy!
By the way, the other causes, like you said, immobility is one. Surgeries is two. If you do injury to your, if you have a leg injury or a calf injury, you can form a clot there. That's where they generally form. The other one is cancers. Certain cancers cause you have a problem with, forming, keeping your blood thin, and so you develop clots. There's certain well-known cancers, lung cancers, breast cancers, that can cause these type of thromboembolic diseases.
Yeah, and if somebody comes in with an embolus like that, and you are successful in turning that around and keeping them alive, then the next thing you do is look to make sure they don't have cancer somewhere that they don't even know about, because it's often lurking about. Okay, somebody called and asked this question, and they said, I went to the doctor. I've been having a little shortness of breath, and my wife says I just snore so loud she can't go to sleep anymore. And they told me, well, I think you've got sleep apnea. He said, then I asked, well, what is sleep apnea? And they said, we don't have time to talk about that now at your next visit. So then he said, when my next visit was scheduled?
A year later.
And he said, 4 months from now. And so he said that was the next available time. So he said, what the heck is that? What is sleep apnea? Gosh, take it away.
Well, I mean, I'm not the expert in sleep apnea, but they have an obstructive lung problem. They don't exhale air very well or inspire very well. They tend to have a rise in their carbon dioxide, a drop in their oxygen. It affects the heart. Sal can talk about that. Generally, people have sleepless nights. They don't have very good attention the next day as a result. So generally, if you are diagnosed with this by a sleep study, going on treatments for CPAP or whatever can really make a big difference in their overall health.
Here's something really interesting, Sal. I was really shocked by this. 18 million people in this country have sleep apnea. I mean, there are a lot of people with it, but that's a big number. And what happens is their breathing at night when they go to sleep is periodic. So it's irregular. They'll take a few rapid breaths, and then they'll get enough oxygen in their lungs then to take slower breaths, and then often go for a period of not breathing at all, just holding their breath, and then real rapid breathing, trying to get oxygen in their lungs again. And then that's where the whole business of snoring and making sounds and being short of breath all the time comes into play. And, there are two different kinds of sleep apnea. One is where there's a thickening on the the muscles in the neck so that it's hard for the air to get in and out of the lung. And then there's one type which is controlled by the brain where there's something wrong. It could be a tumor, it could be some other dysfunction of the brain that just doesn't give that patient the ability to breathe normally. And if you just hold your breath for a long time, that's what happens with people who have sleep apnea all the time. Every night they are in bed and they're breathing fast for a while, and then they stop breathing or slow their breathing down. And in the middle of all that, they make a whole lot of noise.
Let me talk about the sleep apnea industry. This just blows me away. You guys talk about it. The global sleep apnea devices market is rapidly expanding, projected to be 11 billion next year, and then by 2023, by 2030, $23 billion industry of sleep apnea devices driven by highly underdiagnosed obesity.
Yeah. Well, a lot of people have obesity, and that's the reason for it. But,
Yes, yeah.
you know, there are other reasons too. It could be that you're born with that tendency.
Right.
Men are more likely to have it. People who smoke are more likely to have sleep apnea.
Does anybody right now, Sal, do you have trouble sleeping? Danny, do you have trouble sleeping right now? Does anybody?
Oh yeah, I have trouble sleeping a lot, but I don't think I have sleep apnea.
Okay. Because I just got to tell you, it just seems. Sal, what about you? Are you sleeping okay?
I'm just gonna expand a little bit. So, like what Dr. Gleeks was saying about sleep apnea, there's two types we call central sleep apnea, and the second type is obstructive sleep apnea. The obstructive type is the more common type. The one, like you said, is due to the inability of the palate to relax, and it obstructs during your time, usually at nighttime. So you're not getting enough. You're not getting air properly down into the lungs. So the clinical manifestations usually, you know, like you said, a good percentage of the people are obese, but you don't have to be obese to have the disorder. But the majority of patients are usually obese. But like I said, it doesn't have to be that way. They could have present with various types of problems, like what they call is daytime somnolence, where they're constantly tired. If you ask them, like, you know, what are you doing? And they goes, well, I just, you know, during the day, I'd like kind of like low. I just feel like I have to not, you know, I'm not getting, you know, I'm constantly tired during the day, or they'll see them at nighttime. There's nighttime snoring or apneic periods where they stop breathing. You know, the spouse is the one sometimes, you know, I'll get the information from. They'll say, yeah, he snores or she snores like crazy all night long. And I'm worried that, you know, I've noticed that he stops breathing for like 10 or 15 seconds at a time. These are apneic episodes where they like that happens. And so, you know, the worry thing sometimes is, you know, like it gets so bad that these patients, like you said, are so tired during the day. You know, if they're doing any kind of job related, you know, extremely, you know, if they're working on heavy, you know, equipment type of stuff, or they're driving trucks, this is what you worry about. Um, you know, it can also manifest with heart problems, arrhythmias, right-sided heart failure, right side where the legs, you know, you get the belly blowing up, the right side of the body, you know, legs blowing up, getting edema, arrhythmic problems, and then also, of course, you can get, like I said, you know, you could die from sleep apnea, believe it or not. The treatment of it has changed over the years. Like Brett was talking about the industry. You know, mostly it's what they call a CPAP mask. It could be a BiPAP, but a CPAP, you know, constant positive airway pressure mask. CPAP, that's what it stands for. And usually they have the ones now, ResMed, a company, makes a nice device where it auto regulates how much pressure you need to be able to push that air, open up you know, the soft palate down here, and be able to get, you know, oxygen down maybe at 10 atmospheres, 11, 12 atmospheres, 14 atmospheres of pressure. The problem most people complain about with these masks is that they're constantly covering the face, and it's very hard at night. You know, they get paranoid and they can't tolerate the mask. So the companies now have these things called nasal pillows, where they kind of looks like a nasal cannula that sits in your nostrils here, and it's able to do that way. There are other options available. The one I never really liked was where they did this ulnar uvula resection with laser, and you know, these people used to complain of extreme severe pain when they used to like cut off your, you know, that little thing that hangs down the uvula. um, dentists have gotten into the game and they've invented these devices that you can stick in your mouth at night to try to open up your, again, soft palate so you're able to breathe. And there's a new device out. I also believe where you kind of get rid of the CPAP, and I'm blanking on the name of the device. I think it's called Inspira or something like that. Um, and so it's a, like you said, it's a global problem. I used to have sleep apnea when I was 85, 90 pounds heavier than this. I mean, I had to use a CPAP mask.
Wow.
Once I lost the weight, I have I don't suffer from sleep apnea anymore.
Wow.
What they say, what the article that I read just recently said was that very few people lose enough weight to make a difference. So they just have sleep apnea forever. That's why these devices are just being sold like crazy now. And you're right.
They're about
$1,000
a device.
Pardon?
They're about anywhere between $800 to $1,300 for those devices.
Yeah.
They're not cheap.
They're not cheap. And there are a couple of things that make it worse. And sometimes people don't really understand that. But, smoking makes it worse. Drinking makes it worse. And I've had patients tell me if I have one glass of wine before I go to bed, I have trouble sleeping. I have trouble breathing. Now, alcohol causes many people to have trouble sleeping anyway. But the problem that you have with sleep apnea is that a little bit of alcohol in some of these patients make it worse. You know who usually complains about sleep apnea? It's the wife. It's more common in men.
Yes.
And men make loud noise. I remember on a bunch of guys that I skied with for many years, one guy always slept in one bedroom.
Yeah.
Everybody said, yep, that's his room and nobody wants to get close. But I would walk into the condo and I could hear him down the hall. And it was just like in and out, in and out. And I always said to him, I said, you've got sleep apnea. Have you tried to take care of that? And he goes, well, I don't know. I'm okay. I just have a little trouble sleeping. Mm-hmm. So then one day I asked his wife, I said, how do you deal with that? She said, I don't sleep in the same room.
I don't.
I'm down the hall. I close my door because I cannot sleep with that kind of noise.
I do want to say one thing, by the way, for the diagnosis. So there used to be, you have a couple ways to do it. There are home sleep study testing you can do from home.
Right.
They have a way to hook it up. But the better test is the one where they actually have certified sleep centers, usually run by pulmonologists. And by the way, that's a certified exam to become certified in obstructive sleep apnea or essential sleep apnea. So they have those centers now. They also have centers where sometimes they'll keep you overnight and do the study overnight, but you can do it a quick way. Most primary care doctors now order you a outpatient sleep study.
Yeah, boy, up until a couple decades ago, you had to stay in the hospital overnight, and that was the only way to make the diagnosis. Observation and then devices that would monitor you. But just in your office, mm-hmm. you rarely ask a question like, do you snore? But sometimes somebody in the family will comment, why don't you check that out? And then you find out that they have sleep apnea.
I think the conversation on that may come up with regard to what Saul was bringing up. Are you having trouble sleeping enough, feeling tired all day, losing attention, falling asleep in the chair all the time? Yeah. And then it kind of leads to, well, do you snore? And if the spouse is there, says, oh my gosh, I got to sleep, next house to stay, Anyway.
Yeah. Another problem is driving. These people are dangerous on the road.
They're very dangerous on the road.
So, hey.
The other thing.
Well, go, Sal.
One other thing is it's in my differential diagnosis when somebody comes in with paroxysmal atrial fibrillation or chronic atrial fibrillation, any atrial fibrillation for that matter. It's in my differential diagnosis. Do they have underlying sleep apnea?
18 million people have that problem, which is astonishing.
How about right heart failure? You see that?
Yeah, you do. If it gets to that, it gets so severe, their pulmonary pressures get so high, they develop right heart failure.
Wow.
Which is, where you can see, fluid in the belly, big liver, and swelling in the legs.
You got to treat it. You got to be aware that it's there.
Elevated, what they call it, jugular venous dissension, by the way. Forgot about that one.
It's
All right,
there.
guys. Good
Hey.
stuff today. Thanks for
All
30
right.
minutes.
Thank you.
30 minutes and 5 seconds. Look at that.
How
We're on.
about that? What timing?
Oh man.
Perfect.
Hey, you
Go,
guys.
go Spurs, go.
Go Spurs, go.
Bye.
Thanks for watching.
Thank you.